All right, welcome everybody to day 2 of Building for Digital Health, hosted by MIT Hacking Medicine in partnership with Google Cloud and supported by Apple Health. My name is Aditi Joshi, and I am your host and moderator for the week. Now, we are in day 2 of our Tech Talks. It's a daily 90-minute series of Tech Talks, which will culminate in a 3-day hackathon this coming weekend. And we have yet another amazing panel for you today. So now yesterday, we set the stage with Professor Rob Huckman from Harvard Business School, and we also had talks by MIT and Harvard Kennedy School of Government, along with Graham Grieve, who talked about FHIR. Today, we have the awesome Dr. Ken Mandl from Boston Children's Hospital, along with Dr. Ricky Bloomfield and the Apple Health team to talk about Health Kit, Care Kit, and Research Kit. And tomorrow, we're going to have Dr. Oliver Alami, who's a vascular surgeon at Stanford, and he's also the Director of Digital Health Initiative at Stanford Biodesign. And he's going to be joined by the Cardinal Kit team. Now, I've posted all of these links in the MIT HackMed Discord server, so please do go check it out. Now, my goal this week is to equip you with the tools you need to have a successful hack this weekend and give you the opportunity to join the community of like-minded individuals who are passionate about democratizing healthcare. So remember, you can continue the conversation on the Discord server. So the goal is that you'll have these talks, but a lot of the questions might get actually answered in the specific Discord channel that's been assigned for each of the daily Tech Talks. So without further ado, what I'm going to do is I'm going to introduce you to the first speaker. He is patiently waiting backstage. Just to give you a little bit of a background about like the amazing things that he has been doing for many, many years now, Dr. Ken Mandl. Ken is the director of the Computational Health Informatics program at Boston Children's Hospital, and the Donald A.B. Lindbergh Professor of Pediatrics and Professor of Biomedical Informatics at Harvard Medical School. In his work at the intersection of population and individual health, Mandl was actually a pioneer of the first personally controlled health record systems, and he co-developed and leads the smart health IT and approach. Now, this is the key. It's now required by the 21st Century Cures Act to enable a health app to access digital data and run anywhere in the healthcare system. He has received the Presidential Early Career Award for scientists and engineers for his foundational work in biosurveillance and the Donald A.B. Lindbergh Award for innovation in informatics. And with that, let's give a warm virtual welcome as I bring the one and only amazing Dr. Ken Mandl to the stage. Ken, welcome.
Hello, very, very thrilled to be here this morning with this amazing conference.
Thank you. I'm just so glad and just thrilled and over the moon that you're here. So I'm going to turn it over to you because I know you've got a lot to share with the audience.
Excellent. I will jump right in, and I'm going to give you a brief history of this project called SMART, which is an interface between data and innovation, and one I think, if you're interested in this conference, you should be interested in these technologies. Probably you're thinking about all kinds of data that you might be able to bring to bear on healthcare problems, whether you're solving problems at the population level or whether you're solving problems for patients at the point of care or for people at home dealing with health needs and trying to manage their diseases. There are many, many, many different data types that help to characterize patients, from their Twitter and Facebook feeds to their prescriptions from pharmacies to their patient-generated data, to data from financial systems and their, for example, their out-of-pocket expenses, their recreational genomics at companies like 23andMe and Ancestry.com. You want to bring these together, and you want to do it in the context of health system data. Many of these other data sources are actually relatively simpler to access than health system data. So how do you get at the health system data. How do you make your app work in the context of healthcare as opposed to completely separate from healthcare, like most apps today in the Apple App Store and on Google Play? The point of care, so where doctors interact with patients or where patients are interacting with the health system from home, has been a walled garden. And when the Obama administration first proposed to actually invest a huge amount of money, $48 billion, to promote the adoption of electronic medical records, I wrote this piece in the New England Journal that said, if you're going to do this, you really need to let people like the MIT hackathon crew create apps that extend the value of electronic medical records. Electronic medical record systems are generally older, like 1980s and 90s software stacks, monolithic, unmodifiable, and slow to evolve. So what I proposed with Zach Kohane in this piece is that if you're going to invest $48 billion in electronic medical records, put in an application programming interface so that they can work like the iPhone. Now, the iPhone was only 1 year old at the time. And already it was becoming obvious that this API to enable third-party apps made the iPhone much better than an iPhone without those third-party apps. Some of those third-party apps were very, very cool. And we thought that electronic medical records could become a platform for apps like the ones you create. And if it were a platform like the iPhone with an API that was open and public, and by the way, an API that could work with any electronic medical record system, so that those of you out there don't need to know the specifics of exactly how Mass General implemented its electronic medical record and which systems are on versus how it's done at Beth Israel Deaconess Medical Center. That can all be abstracted away from you. So an API that goes across vendor platforms, across health sites, lets innovators post their innovations in app stores, lets end users, physicians and patients, choose from a large selection of competing apps that bring healthcare data into a modern paradigm. Let's look back a few years. When Tim Berners-Lee invented the web, what did he really do? Well, he wanted to share preprints of his articles in the field of physics in HTML, and he wanted, therefore, that the articles would look nice. They needed to have titles and boldface and columns and be able to insert images. And so he invented HTML. And then he invented a way to move these hypertext documents around, HTTP. And then he wanted to be able to render them. So he created the web browser that would render any HTML page, and then a server. And he standardized them. And by standardizing them, he did not need to imagine the full range of internet commerce. He did not need to imagine Netflix at the time in 1992 when he invented this and standardized it through the World Wide Web Consortium. I'm going to talk to you today about some very important standards that have emerged in healthcare that are now regulated and therefore will be available for you to use so that there can be common paradigms for connecting your innovations to the healthcare system. So we ended up parlaying this New England Journal 3-pager into a substantial grant from the Department of Health and Human Services, part of it called the Office of the National Coordinator of Health Information Technology that some of you are familiar with, to actually create that API, something we called SMART. And in this grant, we had the funds, and we brought together an incredible team who still is out there leading health IT. Ask the question, can EHRs, electronic health records, behave like iPhones or Androids, in that innovators readily create and widely distribute substitutable apps across thousands of installs? So when you buy an electronic medical record, you get what you get. But could there be an API with substitutable apps, an app that can be added or deleted from the electronic medical record? When we got the funds, we started off by trying to eat our own dog food. So we took our candidate API and wanted to create an app against it. We were inspired by this article in Wired magazine that looked at the current state of laboratory information systems, crumpled up daisy wheel printer output, stuffed into an envelope and mailed to the patient. And we asked, well, and Wired asked, could some designers imagine a laboratory information system of the future? One designer that was commissioned, Dave McCandless, imagined a laboratory information app like this, showing cardiac risk, cholesterol, CRP, your risk, your smoking status, all the elements going into your risk, put into an algorithm and displayed nicely in such a way that you could imagine this being shared between a doctor and a patient, used by a patient at home. Or I've got a secret for you. Physicians are not so good at figuring out these quantitative conclusions. So this could well just be used by a physician to get the risk data well displayed and consumable in a way that the physician can now make informed decisions. We took this picture, which, as I like to say, was fully operational in Photoshop. It was just a picture published in Wired magazine, a watercolor painting. We gave it to our developer, who was new on the project, because the project was new. It took him 1 week to turn that picture into a fully functioning smart app that was running here immediately across 3 open source electronic medical records that we modified to display our API. So we've got our record system, our API layered on to 3 open source systems, and the app runs unmodified across all 3. So this was a demonstration on that we had a lot of control over, but it was very convincing to us that this was now technically feasible. We had a contest. The Obama White House, Anish Chopra, the chief technology officer at the time, encouraged us to run what I believe may have been the
So Ken, I think we lost you. Let's see if we can bring him back. 1 second. All right.
All right, I'm back. Sorry, don't know what happened, but I'm back.
All right.
Here we go. Can you see my slides? No, I share them one more time. Okay.
All right, I see them now.
Okay.
There you go.
All right. So sorry about that. So, and we get this small company called Polyglot, amazingly able to produce an app in 2 days against our API. And they did this by taking this incredible resource they had, which was patient-friendly, dynamically created medication instructions that were available in 22 languages, replacing those package inserts that are in a font so small that no patient can read them or understand them for that matter. This became a commercially successful app, substitutable initially across our 3 open source systems, now substitutable and reusable across all the major EHR vendors in patient and physician-facing versions. And not only that, but they were actually acquired by First Data Bank and are an ongoing concern. So the idea here is that these smart apps actually have tremendous commercial viability because of their ability to run across healthcare. At home, we asked our chief information officer at Boston Children's Hospital what we could create with our grant funding. And he said, well, we've been on the queue for 3 years at Cerner to get a app that shows patients' blood pressure adjusted for percentile and age over time. Because with kids, that you have to know their age to be able to interpret their blood pressure. And so what happens here? 6 weeks, and we create this app. It took us then 9 months to simulate the API in a real production Cerner system. And within a few days of its being launched, it was being used hundreds of times per week by clinicians at Boston Children's Hospital. This also began to convince us that this model of substitutable apps had legs. By the way, at this point, the EHR vendors are starting to notice that something is going on that might be of interest. We created a growth chart app as well. And we had a design company do it. Came out looking pretty. This is a few years old, but it was really even more cutting edge, pretty looking at the time. And the EHR vendors noticed this. Hey, that looks nice. It's running in our systems. It makes our systems look nicer. And again, this started to get attention. This is what we did within a Cerner system using the existing technology. This is pharmacogenomic decision support, telling a physician that a patient has a variant, a genomic variant, that means that their medication, 6-MP, should be adjusted in its dose. It took us 6 months to get this dialog box into the electronic medical record system, and it wouldn't necessarily run in any other Cerner system, and it didn't actually address other medications or other genomic variants. This is not an efficient way to scale decision support for pharmacogenomics. Here, in a few weeks, we were able to mash up 23andMe data with electronic medical record data, with risk maps showing the meaning of those data in the context of the patient. At Vanderbilt, they created the Smart Precision Medicine Cancer app and started to use it in cancer clinics, very much based on the model I just showed you. We have an app gallery as well. Each electronic medical record vendor has an app gallery. Ours is open and free, and it also has a sandbox underneath it. The largest tech companies in the world use our sandbox to help create their infrastructure and apps, and many developers do as well. What this directory allows you to do, unlike at the Apple and Google store, it adds one additional feature, which is it lets you actually demonstrate the apps, because the data is underneath and the apps can run on real patient data or synthetic patient data underneath. So you can show your wares. we've created a MIT hacking medicine category, and you can actually submit your apps if you create Smart on FHIR apps in the hackathon, and we'll display them in that category. And we've got some directions here, and it's also, these directions are also going up have gone up on Discord as well. Now, let me tell you why it's worth your time to invest in the Smart on FHIR approach. I know you heard from Graham Grieve. You're going to hear from Ricky Bloomfield next, a fellow pediatrician in this space. We were collaborating on Smart before Ricky was at Apple, and Ricky has done phenomenal things at Apple, taking this forward to global scale. The power of regulation is real. Just in November 6, 2016, the feds added in one regulation that said, if you want to get paid your full due by the Centers for Medicare and Medicaid Services, that's CMS, that is a very large line item in the governmental budget. That's healthcare for Americans over 65 primarily. You need to be able to add in to the EHRs the ability for any patient to get their data across an API. Very simple language. Guess what happened? The regulation got people's attention because it's a regulation. And all the electronic medical record vendors got together, and we launched this thing called Argonaut. And in this consensus work group, all the electronic medical record companies got together and layered in the Smart API. The regulation didn't say it had to be the Smart API, but Smart was open, free, and it worked, and it had been demonstrated in real settings. And so Argonaut was a consensus group where we actually pushed the Smart API into real products. Did this work, or was this just a technical exercise going nowhere? It worked. So just after that regulation prompted the vendors to put the Smart API in, Apple used Smart to connect to now over 600 health systems and provision health records to patients. They're Smart up on the Apple stage at the developers conference. And I will congratulate Apple for choosing to connect to health systems using an open standard. And by doing so, all the work that health systems did to make sure that their Smart APIs worked well, had the right data mapped, and that patients could access them, benefits other efforts as well. So for example, a not-for-profit called Common Health has actually followed in Apple's footsteps, creating an Android version of patient access. And that's already been deployed at over 200 health systems in this last 1 year. CMS that I just mentioned, giant line item in the US federal budget, Centers for Medicare and Medicaid, have also decided to give patients access to their data, this time their data from the payer, CMS, through something called the Blue Button, which is the Smart API. There is an interoperable system also to add patient-generated data to the electronic health record data that I'll mention again in a few minutes. And that's called Smart Markers. So that regulation that I mentioned from 2016 was sufficient to give Apple global scale in connecting its health app to health systems and to give patients data from health systems. Something even more powerful than that regulation has recently occurred. In the 21st Century Cures Act, required, and this is due to some very lightweight lobbying that I did, but I managed to get this sentence into a major law, requires APIs providing access to all elements of a patient's electronic health record. 1 year ago, a little under a year ago, a regulation, 1,300-page regulation came out, and unlike meaningful use in 2016, this regulation from 2020 absolutely requires SMART specifically to be in certified health IT. That's in electronic medical records. So you can count on its being there. It's there now, and the regulation supporting the 21st Century Cures Act law requires this. There's a second aspect of this to be familiar with. This won't be as important for your hackathon this week, but it's very worth knowing. There is also something called bulk FHIR or flat FHIR, where the Office of the National Coordinator and the coordinator himself, Don Rucker, asked us to create a population analog to SMART. And so we did. And this allows data sets on whole populations to be extracted from electronic health records in a push-button fashion and in FHIR. This is a very big deal. Think about many, many use cases. Where, doing work within your data warehouse, integration of population health systems into your EHR, reportable disease tracking, FDA post-market surveillance, many, many use cases for population data. That is also in the regs and is coming soon. CMS has already gone to town with the bulk FHIR specification, making payer data available to hospital systems through both the data at point of care and beneficiary claims data APIs. Massive amounts of data will be moving under regulation, under HIPAA, under hospital and CMS rules, but being put into innovative applications and uses. And it turns out that this bulk FHIR API is actually being widely deployed, not only in electronic health records, but also by very large companies, some of which are sponsoring this conference, like Apple and Google, Amazon and others, are building in bulk FHIR so that data will be able to move around in an absolutely principled, reproducible, and standardized way. The federal agencies are coming on board. Very important to know that the data that come across these APIs are actually defined specifically in something called the US core data set for interoperability. And this is in version 1. There's a draft version 2. If you want to help advocate for faster access to data, help advocate for what goes into version 2 and then version 3 so that we can accelerate the data that's mandated to be available across these APIs. Smart markers, this may be very relevant to what you work on this week, is a standards-based extension to SMART that lets practitioners or patients rapidly create apps for patient-generated data. It's a framework, it's open source, and Raheel Saeed from my team leads this project. He's got information about it on, and you can reach him on the Discord channel around Ask Smart Markers, and his talk is on Friday. So there's a whole 21st century IT system emerging. There's going to be a real-world information economy around these APIs. And I will end with a reminder that that I called out when this rule, this 1,300-page regulation was finalized with much fanfare in March, that we must figure out how to be good data citizens as data begin to flow. There is concern that patients will be encouraged to give their data to predatory app companies. There's concern that even though these APIs are here, that there will be a non-market economy where various blockers come in to prevent people like you from getting to the point of care by withholding certain key functionality or by preventing discovery of your app in an EHR-connected app store. There are things that we have to keep an eye on to make sure that an app written once will run anywhere. Any abuses or breaches that become public will slow the ecosystem down. And so we have to be careful, we have to be secure. And then we always want to be sure that we don't widen a digital divide. As effective technologies become available, they can widen the digital divide if there's differential access to those technologies. And there may well be differential access to smartphones, to data, to information that is not presented in a democratic way across different reading levels, cultures, and socioeconomic groups. So this has been a whirlwind tour through a decade of SMART that began in 2009 with a New England Journal paper proposing an API for healthcare. In 2020, that became the law of the land. Along the way, it took a village to get there, and it will take a village going forward to create the innovation on top of this, and also to ensure that we guide the ecosystem towards one where information flows freely, but also securely and respectfully of our patients. We have, and I will end right there, and thank you very much.
I just want to say thank you, Ken. I'm over the moon that you were able to join us today. Ken's team is doing some phenomenal work at Boston Children's, so please do check it out. And I'm going to encourage our viewers to continue this conversation on the Discord channel for today's talks. We'll do a deeper dive on Saturday, but there'll be links that I'm posting throughout the week, and Ken's team is posting throughout the week just to help to get you started. So thank you again, Ken. I'm going to move you backstage and introduce our next speaker. All right, I'm going to turn it over to Dr. Ricky Bloomfield and the team at Apple Health, but let me just give you a quick bio about Ricky first. So I first heard Ricky speak at one of the digital health conferences. I think it was like HIMSS. This was probably, I don't know, like 10 years ago. And back then he was at Duke Medicine. And I remember thinking to myself, like, who is this guy? Because he totally gets it. And years later, he is at Apple Health doing all these amazing things that he was talking about when he was in North Carolina. So that's the unofficial intro, but here's his official intro. Dr. Bloomfield is a physician, an entrepreneur, he's a developer, and he's into clinical informatics. And he's passionate about using technology to improve the health of all people. So +1 on that, Ricky. He joined Apple Health's team in November of 2016 as a clinical and health informatics lead, where he works on products that empower patients to improve their health. And prior to joining Apple, he was the director of mobile technology strategy and a pediatric hospitalist at Duke Health in North Carolina, where he began a personal mission to liberate EHR data to empower patients and clinicians to solve healthcare's biggest problems. So I love that. We share that same mission. And with that, I'm going to turn it over to Ricky and the Apple Health team. And the team will also give you some background on Health Kit, Care Kit, and Research Kit. So thank you so much, Ricky, for being with us today.
Thanks so much, Aditi. I'm super excited to be here with you, and I really appreciate all the work that you're doing to shine a spotlight on FHIR, on standards, on the ability for developers to create amazing apps. And also, I want to thank Ken for all the work that he's done. I've had the opportunity to work with Ken. I think we originally connected in 2013, so going on better part of a decade in seeing this journey of interoperable health data. And he has been such a great leader in pushing this work forward.